here? Oh, it is, of course.
Sorry. Good morning, everybody. It's my pleasure to introduce Kostkova from the University College of London. She is a principal director of e-health research. Now she's trying to build up all the integrating different resources from the UCL in London around digital health, including serious games and also learning analytics. So it's my pleasure to have you here, and please, we're very curious about your work, so please.
Thank you very much, Walter, for the warm welcome, and thank you for coming here on a Monday morning. So I will, in my talk, I will describe the work undertaken by my previous group at City University called City eHealth Research Center. I came to UCL 2 years ago, so we transferred the work and we're continuing some of the research, in particular research into use of social media for early warning for public health and use into serious games. So the work I will sort of cover, I will give you some sort of overview of the social media work and analytics work we did for medical portals at City University with my colleagues over there, and then I will continue to focus on the games as this seems to be your major point of interest. As the group is so small, just feel free to interrupt and ask questions anytime you have any idea or any questions. Don't wait until the end because it's very small and sort of intimate group, so I think it's going to be much more cozy than we expected. So, well, as you know, the internet has completely revolutionized the way we deliver health. Especially in the US, where healthcare is private, you know that this is something which has created a completely new direction about 10, 12 years ago, when everything has been on the internet. Patients suddenly became empowered, they can access the same information as doctors, they can ask doctors questions they don't even know the answer for because they sometimes cannot keep up to date with the latest evidence. And as you know, internet is now available absolutely everywhere. The other major shift was when mobile telecommunications and mobile phones coverage became basically widespread. It's about 31% of the population of the United States is using their mobile phone to access health information. They're checking their tests or they can access evidence using their mobile phones, which almost doubled since 2010. So the use of the phone is now basically replacing the desktop computer. We want to know on the go, wherever we are, what's happening, and the phone has now become a completely ubiquitous device. So 10 years ago, when we started working on the e-health research, there has been a major project in the UK addressing the issue of information overflow. And the issue is something which I'm sure you know, or is not completely specific to a healthcare domain. So the information you may have is often not the information you want. The information you want may not be what you need. What you need, it may not be known, and if it is known, then what? You can't find it inside. And it's something I think we all have encountered in our life. You're looking for something, can't find it, what we find is not what we wanted, or it's too late, etc. So this has been a major concern in the UK 10 years ago, and the government set up a project called National Library of Health, which was a large sort of government NHS-funded project to give the best available evidence to professionals in the NHS through a website. It was quality assured, and that it was always having the latest evidence. So if the doctor is seeing a patient and they would check something, and of course they're not reading all the papers because they're just too busy to read all the papers, they can go on the library, find the information, and be reassured this is the latest evidence. So this was kind of the idea behind the project, and we were in charge of a project called Nelly. It was the first project which was part of this big UK National Library of Health, specific to infection. There were about 25 or 30 different specialist libraries for each condition and each disease, and the infection was one of the biggest one. So basically it was a one-stop shop kind of point access to give people information. We have content managers who were professionals from infection and public health, who were doing the searches, including government documents and consultations and guidelines, and they were all putting it on Nelly and lately NRIC, Infection Control project, which we also were running with the Department of Health, so as the professionals can find information and know it is quality assured and up to date. And then since then, we've been running about 10 projects in different parts of health, mostly linked to public health infection. And we also, because the model was working so well, we also got a grant with optometrists who needed information about optometry, about your prescribing of drugs for optometrists, who often, again, they have a private practice, haven't got time to be up to date. So they were coming to a project called the supporting for optometry. So there was a variety of things we were actually running for professionals, but at the back of it, we were using the data we collected through the interaction for data analytics, learning analytics, to improve the services, but also to learn about our research, to learn about how people are actually using it, and what works and what doesn't. So, how are we evaluating these portals? So, we have used a number of methods, so I'm just going to give you a brief introduction about kind of these methods we initially used to understand the users, and then I will sort of move on to the work on Twitter and games. So what you can do with any website, because they have some evidence from the weblogs, so we did a lot of work on evaluating weblogs to understand where people are coming from, what is the traffic looking like, what is, for example, the geolocating the data, so we know where the searches, for example, are from. We was looking specifically at the flu season searches in 2009 or 2008, where people actually are searching, what is the keywords, etc. We also did a specific evaluation of the traffic and interaction with the website during specific events. So the content managers used to go to conferences. ECMID is one of the biggest conferences in microbiology. And we look at how promotion at a conference, using a conference sort of table, an exhibition table, showing the site, talking to professionals for like 4 days, how it impacts on the traffic on the site, and how long the traffic stays, and it comes down Saturday, but then it went up. So usually we could evaluate not just the interaction in a normal setting, but also specifically about events we have been using for promotion and engagement with the user base. We also did a lot of evaluation of how people are actually navigating the site. We initially thought people would be searching because we used to, Google and the major search engines. So we invested into our search engine first, but then we actually realized that browsing is actually quite more popular. So a lot of people come to the site, they check the navigation structure, and they tend to browse the site more than actually search using the search box. It was something we didn't initially anticipate, but then we had to improve the navigation structure and the taxonomy to make sure people actually find what they're looking for. When people do search, this slide should go back about 5 years. It doesn't matter, I don't think it has changed really. When people do search, so it's a minority of users, they tend to search using a single keyword, which is okay, they write a keyword into the search box. And the second most popular is a phrase. So 32% of users actually use the whole phrase. People are searching something like, I want to know something about swine flu in children, blah, blah, blah. And then obviously got no results because the search engine would only look for the keywords. There was a lot of understanding of how the search engines are actually built. And people using typically Google and being used to that, people can pick up all the keywords. In this case, they were getting no results. So again, we have to look into this more. We also allowed a lot of sort of Boolean operators and various filtering by documents, by author, by publication, by years. But this has been hard with every years. Even the Boolean operators have been used only 50%, and this constitutes and or. So nothing more complicated was actually being used. So the usability of the interface is really important to get things right. We also look at just passively how people are using it, but what actually they get out of the site. Do they get any knowledge? Do they actually change their understanding of the domain if they are using the site? What are their initial information needs when they come to the site? we obviously have got some description of remit from the Department of Health or the funding body, assuming this is what people will want. But in reality, we found that actually sometimes they didn't want what we wanted them to want. So we have got an evaluation of traffic coming externally from Google and search engines into one of the projects, which is specifically a study looking at a website for public called Bugs and Drugs, which is explaining the concept of antimicrobial resistance, antibiotics overuse, and the whole issue of antibiotics being prescribed for coughs and colds and basic illnesses when they are not needed. So it was trying to educate public about this growing important phenomena, to reduce the pressure typically parents put on their GP when they have a child ill. They try to give antibiotics, believing this will fix it, not understanding this wouldn't. And this study, was kind of trying to understand where people actually come from, what is their initial point of access to the internet, which brings them to our site. Hopefully they will learn about antibiotics. So we evaluated this with keyword searches, bringing people to the site Bugs and Drugs. What do you think is the most popular search you would type into Google or any search engine which may take you to a site about antibiotics? And it was a surprise, right? So it wasn't what we expected, and it wasn't what the site was actually designed to educate about. So it's something which reveals what public needs to know, as opposed to what Department of Health thought people need to know. Any ideas? Or would you not ask your GP when you're given antibiotics that you actually need to know, and you would go to the internet in the anonymity?
Sex.
That's a common answer, yes. Thank you very much for bringing it up. Yes, there were some sex-related, STD-related questions or queries, but not the majority. The majority was something which is related to antibiotics, and it's an activity people often want to do and often have a myth they're allowed to when they are taking antibiotics.
Alcohol?
Alcohol, absolutely, absolutely. So anyway, the majority of questions were about alcohol and antibiotics and drinking and antibiotics. People wanted to know if they can drink or not, basically, when they've been given antibiotics. And as you can imagine, it's not a question you want to ask your GP. So we were looking at the searches, and as I said, the majority contained the word antibiotic, and the combination of antibiotic and alcohol was by far, by magnitude, the most popular. We also have other kind of typical keywords which brought people to the site. An interesting one was that quite a high number of searches included the word cat. And there were no dogs, so no other animals. You're just wondering why people are searching for cats when the site had no information for animal health or animal antibiotics. It was specifically for human health. So we looked into which pages actually Google indexed to bring people to retrieve when they search for cats and antibiotics. And it actually turned out it was like sort of uncontextual indexing by the search engines. We used to have pages which were linking to an Oxford University project called Critically Appraised Topics. And it was called CatBank in a sort of scientific language, containing a sort of lay language description of conditions and diseases which public could know. So if you wanted to have a quality assured information, you wouldn't trust Wikipedia, you could go to the CatBank at Oxford University and access the information about any medical conditions. So in our site, we used the CatBank. If people wanted to know more information, we gave a kind of a summary for each FAQ, and for more, access the critically appraised topic, and we gave links to specific pages in the CatBank. So the word CAT, in capitals as an abbreviation, did happen to appear on a number of pages for this reason. Clearly it was misindexed, and people searching for information about cats ended up on this side, being, I think, by surprise, what on earth they're supposed to find out on a site about antibiotics. Some interesting thing when working with antibiotics also took people to our site. Some animal information also comes of interest. Swedish acne remedy, no idea what people wanted and why this was taking them to the site, which has got no remedy for acne. And when I say Chinese formula, so really bizarre searches, but I'm going to look into what is being indexed and actually was clicked through to bring people to our site. And luckily enough, we've been running these projects for a number of years. So the NELI, the first one, has been going for about 10 years. Then the second and biggest one, the Infection Control Library, is already 7 years old and has got user base from all over the world. You know, working with Africa, to pilot it in Africa with professionals in low-income countries. So luckily enough, we actually have a longitudinal data set from the weblogs, reflecting the changes in those years in terms of search behavior, search needs and information, and basically analytics. So a couple of years back, we put it all together and we thought it would be great to actually see how and what was being searched throughout the years on those sites, the professional sites, in comparison to what Google was putting up as a public trends and public searches. And we also looked at how it was influenced by media coverage. Because as you know, the media are obviously very keen on any outbreak or any infection, anything which looks, you know, like affecting the humankind. So the coverage of infections has been, especially some sort of pandemics, has been really massive. Not just in the UK, I think everywhere. So we looked at what Guardian has pulled together information published from newspapers in those periods as a public database you can access for news. We compared it with the web server logs on NELI and NRED throughout the 5 or 6 years. And also we use Google Trends data for comparison with public information needs and searches. And we look at a number of major conditions and infections. I think the interesting one is MRSA, which, you know, clearly has been going up and down in infection, depending on if there was or was an outbreak. It was really popular before the last elections in the UK because it was a highly big election campaign. But as you can say, kind of the Google search is going up and down. There wasn't any major sort of change. The news articles have got some major peaks, which was typically around a major hospital outbreak and people dying. All these scare stories were picked up by media and covered. And as you can say, the red line is the professional searches on our sites. So it's not really reflecting the media coverage, which is actually a good thing. It's not the professionals going to search for something because there is some scare in the media. In some cases, there are loads of peaks of information needs which do not reflect any media coverage. So when we actually look at what those peaks are, they were typically caused by a publication of some new government guideline or document. People needed to know around infection or MRSA or superbug coverage. Or they were part of a professional, like WHO consultation process, for example, for some new SOP or a new policy. So typically the professional needs was driven by a publication, while the public needs, sometimes it coincided, sometimes it did not coincide with the media coverage. And the interesting disease, as you all can tell, was the swine flu in 2009. When during the pandemic, obviously the Google searches, the public interest has just completely rocketed. You know, it was 5 magnitudes higher than the normal search for swine flu, and it went up during the spring peak in sort of July, and then it went down because people thought it was quite serious, and then there was a small spike in the autumn when the second peak came. As you can say, the news articles were kind of reflecting it, but not really. Obviously, massive coverage, the green line in the spring peak, even though, according to comparing those two sources, the interest of the people preceded the actual media coverage. So it wasn't causing the panic. The media were covering it after the public actually has been frantically searching for information about swine flu. This is quite an interesting result. And this is what we will actually bring together with a little bit of stuff we did on Twitter and the social media information needs and sharing. So I'm going to say this about 2 minutes later. Perhaps unsurprisingly, the professional needs, the NELI searches, they do go up and down. I think this one was the introduction of the swine flu line in the UK. So when in mid-July, when it was no longer possible to contain the pandemics, the Department of Health opened a special line, which was a phone line you could just call. You didn't have to go to GP, you just call the line, you say you have your symptoms, you think you have a swine flu, and you will send Tamiflu or drug by post. So they tried to reduce the pressure on the healthcare service just trying to give people the medicines over the phone. So it took about 3 months to actually get it sorted out, when it became clear it couldn't be contained by contact tracing in the initial period. So obviously there was a major change in the way the public health services responded. But in terms of information needs, there hasn't been anything really as major as public interest and the media coverage we have witnessed in the first peak. So moving away from the sort of weblogs analytics work we have been doing quite a lot in various studies and for various projects. The other method we have been using is looking at how knowledge and attitude of users have changed using pre- and post questionnaires. So the website about the antibiotics, the one people wanted to learn about alcohol and drinking on, has been evaluated several times a few years ago. Now, the biggest study was done in a science museum in the UK, where we just went on computers. We asked people who were visiting the museum to come and look at the site, and give us pre- and post questions regarding middle ear infection, AOM, which is quite common in children. And we also have a bunch of questions about their attitude. So they still, after using the site, they still expect their GP to prescribe antibiotics for AOM, and try to assess how their knowledge had changed, hopefully improve, but how their attitude towards antibiotics have changed. So you can see the biggest change was the second question we asked them, whether people can become resistant to antibiotic. And you can see there was a major improvement in the post question here. Well, the reason for that might be twofold. One, people kind of knew something is going on about the resistance, but didn't quite know what it meant, and they realized it's not the people, it's the bugs who become resistant. So they got this wrong before using the site, and after using the site, they clearly understood better. It's not people who become resistant, it's not us, it's the bugs. So they got it right. The second reason, which we do not have an answer for because we couldn't repeat the study in a different setting. The second reason why this was so popular question, which actually went from wrong to right, is because we had a so-called tip of the month kind of feature on the homepage of the site. So if you open the site, there's a tip of the month kind of question, and the months when we were doing the study in the Science Museum, the second question was tip of the month. So everyone, when they came to the site, they could see the answer to this question straight away without having to search through the site. So I think it also contributed to people just seeing it, regardless of their searching behavior, and maybe that's why they also improved the knowledge. The interesting thing is, when we try to combine the attitude and the knowledge change. So we were hoping, this site is teaching about antibiotics, so people should learn how antibiotics work, which would improve their knowledge, and they should also change their attitude. So they should become less expectant of GPs prescribing antibiotics. So you wanted people to increase the knowledge and decrease the attitude score in terms of expecting their GP to prescribe. So in this bottom quadrant, when you combine the attitude and knowledge questions before and after, you were expecting the majority of users to end up. As you can say, we only have 24% of the users in this quadrant, and we have people who decrease their knowledge and increase their attitude score. This is the worst possible outcome, right? So they knew less after the site, and they were expecting even more prescriptions to be given. So this is the kind of completely lost hopes. But it's only 5%. The interesting is are these people, because they increase their knowledge, so they clearly learn more about the antibiotics and how the bacteria and viruses differ, etc. But they increased the attitude score, so they completely didn't get it about what is the phenomena about, and they were still expecting even more prescriptions than before using the site. So kind of the relationship between attitude and knowledge is much more complex and requires more of some psychological understanding and intervention, because this is something which kind of was not what we expected to happen. So moving on, number of these sites is obviously teaching something, is educating people so we can use the analytics, but it's also developing a community. So if the site has got a target audience, and typically a professional one has a very clearly defined target audience, we need to also understand how the community of professionals is interacting, and if there is some sort of Web 3.0 feature, so discussion for wiki contributions, how this is building into new relationships, or how different roles in the community typically relate the physical roles in the real life, and how the internet can help. So our biggest project in this domain, with the kind of Web 2.0 community element, is called FEMWiki, so Field Epidemiology Manual Wiki. It was funded by ECDC, the European Centre for Disease Prevention and Control in Stockholm, and it actually brought together a large European community of epidemiologists who are being trained by ECDC, work in different countries in Europe, but need to understand field epidemiology. And people who are sort of alumni who graduated from this program, they get a job somewhere in Europe, but they also are part of the process, and they are also mentoring the junior people. There's a large, several hundred, maybe 1,000 people community which is around this program. So we developed a wiki platform where they have a basic training on the wiki. We also developed, and as you saw, you can edit this page as a wiki page. And it clearly shows who are the editors and who are the contributors. If you are the top contributor, you will come up here in the list as a top contributor. So people kind of know who is behind the page, who has been editing it. And because they know each other, it's a community of kind of colleagues, that it is giving a sort of credibility and kudos to the site. We also developed a semantic sort of taxonomy, where we indicated the kind of keywords and pages we already have the content for from the initial part of the project. These are in yellow, these are in blue. And we also identified a number of keywords and terms which we didn't have any content for. And we let them as a kind of red highlighted in the browser, hoping people seeing it, they will actually come to the site and fill it in. And actually it has been working. So over the years, those red taxonomy keywords have been becoming full pages, and people are now working, filling it in. So it is kind of helping to expand the initial resource much beyond using the community. So what about the interaction? Well, we look into how people were interacting with the site. At the beginning, there was this kind of initial developmental period. We have a number of quite senior editors who each took responsibility for part of the site, which initially existed on a paper format. So we migrated it over, and they were developing it over like 6 months period to create an actual basic resource with the basic evidence before these additional pages were being created using the taxonomy. So this was a very kind of active, each line is a user line. It was a very active interaction by the initial set of about 12 editors. In November 2010, we launched the project at the biggest European conference in public health called ESCAIDES. And we had an exhibition stand, we were giving away t-shirts and pens, and if people signed up, they got all these presents. So we got loads of subscriptions here. In like 3 days, hundreds of people subscribed to the project. But as you can say, only a few of those who subscribed at the conference actually remain active and were coming back to the site to actually make some changes. So these are users who make changes, not people who just come and read. So we started looking at, and now the site is having about thousands of users, and it's becoming more active. But the interesting question was, what makes people come back, what makes people to be active contributor, as opposed to just someone who comes and wants to read. This doesn't include the anonymous users, so there are more people who are using the site anonymously, and we can't track them. So we looked at the people who actually registered. What was their relationship with other people on the site? So each number is a user, and if a user is connected with another user, it means they have been contributing to the same forum. So if there was a forum debate, for example, we look at the users around the forum and see how the community was evolving. So who replied to who asked the first question, etc. And you can say that in some cases they're isolated users, but over the time they were getting more and more active, and people were communicating more around the forums. So we looked at what kind of roles these people played when they were communicating to various forums. So we look at the people who we notified in red. They are the people who send the first reply. So typically they are the senior people, they see a question, they go and answer it. And we look at the people who are the most active people, the blue ones. So they send the first post, so they initiate a new debate, and then new thread, and they go out and ask questions, and initiate discussion. But they also are posting the first reply. So if someone sends a question, they are keen to answer. So these are the kind of cornerstones, the blue ones, of the community engagement. And the green ones, typically it's like more junior staff who ask the first question. So they first posted on the forum, but didn't feel comfortable to answer questions someone else posted. And then you look at the various forums, and you look at how many people were in which row. And the interesting thing was how things were kind of changing over the time. So we had about the number of people who actually sent the first post. Initially was quite small, but over the time, as the community grew, people became much more confident to ask questions because they knew someone will answer it. The number of the green ones who were just sending the first question have been really growing up, especially with new cohorts starting the program. And the people who were the first respondees, it roughly remained the same. These were typically the people who were quite senior in the program, who were keen to answer questions because they knew it's important for the junior people to know what the answer is. But interestingly enough, the people who were both the first sender and the first responder, so starting new thread and also responding to blue ones, has also been slightly expanding. So ideally, you try to expand the blue ones even more, and then have the green ones, should be anyone in the program should be free without any fear to actually go and ask any questions. So there were still some issues around that. And mainly those kind of people who were in isolated groups in the big graph were people of different language. So they didn't feel comfortable speaking English, so they had their Slovenian or Portuguese little group where they connected each other together, but they did not contribute to the big English-speaking community. So they are culture things as much as medical and technical. So then looking at our work around Twitter. So it started 3 years ago. A colleague of mine at the KMZ thought, let's just collect Twitter feed about flu and influenza and see if people are talking about it. And in 2009 until the sort of beginning of 2010, we just had a pilot study, which at the end kind of brought a new project, looking at how people were discussing influenza on Twitter. At those days, it wasn't a popular media, there were no celebrities on Twitter. If you wanted to retweet, there was no button on your client, you had to write RT, retweet it. So it was really kind of in the archaic days of Twitter. How many tweets do you think we collected at this study discussing influenza or flu since May until the May next year?
Millions?
Millions, yeah. 3 million tweets we collected. I think now 3 million is nothing, right? But in 2009 it actually was quite a large data set.
Maybe you can repeat now with Ebola.
Absolutely, yeah. It will be billions. And we only focus on English-speaking users, so we only search for like flu influenza in English, so there would have been more in other languages, of course. We looked at how the swine flu could be, how the Twitter could be used as an early warning mechanism for outbreaks. So we look at specifically people who were saying, I have the flu and I have swine flu. So 25,000 users from this 3 million data set actually kind of self-diagnosed themselves. And he thought, well, okay, let's see where they are from. So we broke it down to US and UK users, because it was the majority of users were UK and US with some other countries, but these were the 2 main geographical locations. And you can see in the UK there was like the first peak, and then it went down in summer, and we lost some data because the engine crashed, so we restarted it. And then there was a little bit of a second peak in the autumn. In the US, it was much different. It was a much bigger discussion on Twitter in the autumn peak. The interesting is the early warning opportunity for Twitter and social media data. So we looked at the UK Twitter discussions, which is the square slide. And again, the first peak is big, summer is kind of quiet, second peak is the autumn one, which is slightly lower, but still significant. And we compared it with the officially reported swine flu figures by Royal College of GPs, so RCGP, which is the squares. So, as you can see, the Rollercoin has peaked here, but the Twitter has peaked about a week before. So, if you look at the discussions on Twitter, it gave the authority, it could have given the authority, it was not a posteriori, it could have given the authority about a week of difference. In reality, it was 2 weeks difference, because in reality, it takes about a week to collect the data from the GP level, the regional level, the national level, and combine them together for some actionable figures. So in reality, about 2 weeks before the HBA or PHE now actually knew there was something that was magnitude higher, we knew from Twitter. So the potential for early warning is definitely there. People are using it in real time. They tend to be discussing it on Twitter far before they go to see their GP. If it's something like flu, some people never go to see their GP because they just get better at home. So I think the social media is an enormous information source for community disease prevalence and also for early warning system. Obviously, this is just a pilot, so it's a long way to go to make it really robust and make it work for any condition, even something which isn't as popular or as realized like swine flu 2 years ago. We also did a small study looking at one specific event during the pandemics in 2009. Do you know what happened on 11th of June 2009? Do you remember? WHO declared the pandemic. So level 6 is the highest pandemic, which is of global importance. This is Dr. Chan, the WHO Director General, who is announcing on 11th of June that the pandemic is now at level 6. There were discussions whether it was correct or incorrect decision, but regardless of that, it created massive buzz on Twitter. And so the world pandemic happened to occur in the frequencies like a magnitude higher than any other keyword in the 9 months period we did the study on this very day. What we looked at was how Twitter is being used not just as a data source to collect information from users, but also how it's being used to disseminate information back to the audience. So we thought, let's look at how the Twitter was responding 24 hours after this official announcement. Who and how many users were sending links to a media coverage of this major event. And as you know, any media outlet you reported this news, it was such a big news. So we looked at how many tweets contain a link to a media article covering this pandemic declaration. So at the beginning, there wasn't kind of much happening. It took a while. Then, as you can see, the red line, which is CNN coverage was picked up by Twitter and was being retweeted. So this is a number of users on Twitter who have been retweeting it. And after 2 hours later, when BBC came, the blue line, BBC completely shot it up and then stayed the most popular retweeted resource until the end of the 24-hour period. So in a way, looking at say the quality of CNN, the quality of some of the media, the quality of BBC, people still reported, even though BBC was well after, 2 hours after the CNN, they still had reported or retweeted the BBC link much more than, say, the CNN link, which is the second most popular. As you can say, retweeting the WHO official press release or the CDC, nothing. You had like less than 50 users retweeting the official coverage press release on those organizations. ECDC, the European, didn't even make it in the chart. So now showing this at the WHO, they were like laughing, thinking, it is just impossible to expect people to be actually following press release given by the organization unless it is covered by all the major media outlets, which actually is what is getting the message out. So the collaboration between the organizations and the media, especially the high-quality media like BBC, is essential for any risk communication during emergencies. And now we're pulling things together, not just looking at Twitter and official surveillance, we're also looking at various media scanners, systems like GP and Medicines, scanning the media coverage for around the world. And also bringing this together with self-reported data and anticipatory surveillance when people are themselves reporting their conditions and their symptoms, and developing a system which will pull it together and try more robustly to identify when there is an outbreak and also support the actual process of investigation and response. So our kind of new project is trying to develop a many-board platform which gets all the data feeding in from the filter from social media, etc. And it's looking at what is the current coverage, and if it's international, this is just a mock-up showing on the map where and who is responding, how many cases there are. So this is kind of work in progress at the moment. Okay, so in the final part of my talk, I will look at the games. So finally we made it there. The project we have used was initially the funded big EU initiative called EBAC. Spain was also one of the partners. So we had a project which developed a pack to go to school, like a small textbook, and games to accompany the pack, teaching antibiotics, basic hygiene principles, respiratory hygiene, and kind of basics about bacteria and viruses. It was developed by the HPA in the UK. So the university developed the games, and then all the countries, at the time it was 10 of them, translated it into their own language. And at the end, ECDC liked the project, so they funded translations to, I think, all the 28 countries in Europe. The initial countries, and these are the initial ones in the project, they actually had people on the ground working with the Ministry of Health and Education to translate the games and the pack and actually send it out to schools so kids could actually be using it. So learning objectives were defined by the project advisory board, covering things like kids understanding what is fungi, what is bacteria, what is virus. We have fantastic artists who work on the project, so they could draw cartoon-like sort of images of the bacteria, but they actually resemble the way they actually look under the microscope. So this is how I think a penicillin looks like, is the one with kind of these heads, etc. So they actually look like the little ones. You know, an objective was bugs are available in any location, so they could be inside your body, they could be in a kitchen, they could be on your skin, etc. And the player is investigating the locations and is learning how the bugs interact with each other. So we developed, it was a part of the project, 2 different sets of the games. One was a platform game aimed at the junior children, aged 9 till 12. And one was a kind of CSR-like game using storytelling as a mechanism for kind of senior kids, so aged 12 till 16. So at the junior game, there's a number of learning objectives being taught through different levels. And in each level, you have a basic task to do. So like in this one, you are in a kitchen, you are running around, she is here. You can choose being a boy or girl, so this is a girl. And you push loose lactobacillus into a glass of milk. And if you push 3 of them, this is just a demo, it turns into a yogurt. And when it turns into a yogurt, kids are being told the bacteria could be put in good use. This is how we make bread and yogurt. It's not only the bad bugs making us ill. So other one is teaching about food hygiene. So you're supposed to be sorting all your food into the right places. So for example, food goes to a food bowl, meat needs to be wrapped up and goes to the bottom of the fridge, food goes to the food bowl. This is meat to the fridge. And after handling raw meat, you need to wash your hands before you handle vegetables. So this was correctly done. And in this case he sneezed, but he did not use a tissue to protect the sneeze, and he did not wash the hands before handling the orange. So again, this would deduct the point that it was incorrect. So this is an example how it was done correctly. He was sneezing, but quickly caught the tissue, so he protected his sneezing, so now it was okay. And this is now correct. He washed his hand. He wrapped up the meat into a foil, so the foil protects the meat from dripping the fat into the fridge. So that this is correct, and that's it. If there's anything rotten, there is a big bin on the corner, and we're supposed to be chucking away anything rotten into the bin. So it is just trying to understand how cross-contamination that happens in your hands, how things should be in the fridge, meat at the bottom, and the vegetables above, and making sure you wash your hands if you're handling raw meat and vegetable, and if you sneeze, you need to protect yourself or wash your hands afterwards. And points were given or deducted. And the final demo for a level teaching antibiotics issue. So you can see horrible superbug in your body, and you have antibiotics you need to throw at it. to get it destroyed. So see, it is being destroyed by antibiotics. And the learning objective in this one is trying to teach the child that you have to finish your course, even if you feel better. It's more for the parents, but if you feel better after 2 days, you have to finish the course you were given by a doctor. You shouldn't just stop using it. So in this case, if the player is not using every single pill, it looks like antibiotic is already gone, the infection is gone, but the antibiotics have not been fully used. There is still one pill she has got in her course. So what happens? The infection comes back, and you're gonna lose points for that. So when it comes back, she has to use the final antibiotic in the course, and now it is fully finished. So teaching to finish the course was something that was very important. It was seen by a lot of people in the UK. Maybe it's not an issue in Spain, but it is.
Actually, it is.
And people have been in the UK as a study, and it's really interesting. People have been keeping their own antibiotic and giving it to their animals, like to their dogs and cats, because it's expensive if they go to the vet to buy ones, while if they get it for themselves, it's free. So then these things happening like this. People were keeping it for last year, and then next year, if they get a flu, they were using it themselves, even though it was a leftover. So the whole concept of how it actually works there were so many misconceptions. So this was something people felt was very important to teach. So we did an evaluation of the knowledge gain. So the one which was the most successful was the one with the milk and the yogurt. So understanding how we make yogurt had the highest sort of increase in pre and post knowledge. The second one was if you cannot see a microbe, it is not there. So again, they understood you don't have to see it's too small, but it is there. And using soap to wash bugs away, again, was the third one in success of thinking on objective understanding. And we also looked at, well, if the kids are playing this game, they're given the task, the kind of a phone, and then they go into the level I've shown you. Are the kids being taught by the mechanics? So it's like pushing the bug into the milk. Is it actually what they understand is making the milk, or is the description, you need to push the mousse into milk, is the text, which actually explains the concept well enough, so they would understand it anyway? Or is it a combination of both? Is it the text or mechanics? So we did a small study, and we picked up 2 objectives which were really successful according to this big evaluation, and 2 objectives which were not successful. So we tried to mix match the good ones and the bad ones. And we split kids into 2 groups, and one was being taught objective 1 and objective 2 using text, and we just took out the game element of it, and then they were learning the mechanics in 3 and 4, and the group 2 was the other way around. So they were being taught 3 and 4 using text, and 1 and 2 using mechanics. So we had 2 different versions, and we knew the objectives was a mixed bag, so 2 successful, 2 not from the previous study. So we actually couldn't conclude any significant outcome of this, and perhaps this is not surprising. So there was no specific significance in one way or the other. So it looks like it depends on the actual learning objective and how well it is being taught using the specific mechanics of the game, which determines what is being successful. Is it the text, or is it the mechanics? The one where we did measure statistic significance, where the mechanics was not available, it was the one with the yogurt. So again, even this study demonstrated the yogurt one was somehow well designed, that it was actually making kids to learn this more. So basically this mechanism was the one which we can confidently say it worked. The only thing about this study, it was only done on a small number of kids, as in 20, so it would need to repeat it on a larger number of kids to actually see what happens if it's one way or the other on a larger sample set. Or try different mechanics, but then this would be also additional to the project. The other thing we have started looking into recently was, it was all done for the needs of DG Psycho. So the game was designed and kids were evaluated using initially like paper questionnaires, online questionnaire before and after. And they obviously hated it. They complicated for the questionnaires or something. They just were randomly choosing the answer in the middle. The results were really kind of biased because it wasn't a popular way of asking kids for questions. So we looked at how else we can actually understand, how can assess the knowledge of the player without asking the kind of standard survey questions. So we look at a principle called schema evaluation, and we thought that you have kind of different levels. The evaluation is something where you can actually try to build it into the game itself and see if the child doesn't actually understand it is a part of the evaluation, if they think it's actually a part of the game, then the results will be far more realistic and less biased. And obviously you can have higher engagement. So for the junior game I've been describing, between those levels you've seen, there is some kind of, we call it a game show. And the game show it was David Farrell's idea. It's something like, you know it from Spain, How to Be a Millionaire. It's like a TV program. Yeah. So you can go into the TV show, there's a house, and you are one of the players, there's a second player you are competing with, who is just artificially generating the answers, and you either win or lose against this player. And you ask questions which were taught before and after the game level you just played when you go into play. So basically you collect your data right before and right after the level, but you do it in a kind of a funny way with, the game show making jokes about you. And because of the competition element with the second sort of invisible player, it is much more engaging for the kids than just being asked questions like this. So we look into how they actually liked integration, and if they could tell they were being assessed, or if they just thought it was a part of the game. And they also were to describe if they thought it was a fun or how they like to play. So actually the results were quite positive. They did say the game was fun, etc., nice to play. And 60 kids prefer the game which was integrated. Interestingly enough, 30% said the game was more interesting. And the interesting thing, the 15% stated the quiz did not affect their game experience, but they prefer not to have it integrated in the game. So if it didn't affect, why they wouldn't want it. 60%, and that's important, did not notice that their knowledge was being evaluated through the game. So in a way, whatever they thought about the actual layer part of it, 60% did not know they were being evaluated. So the whole kind of discouragement which comes with assessment and tests was taken away by most of the kids. And the second game, just to finalize the talk, was the one for the senior children, so aged 12 to 16. And we used a detective game, similar of the concept of CSI, using interactive digital storytelling. And we developed 3 missions, and in each mission you are given a task by your manager, like in Big C. You go into the country where there's an outbreak, and you speak to people, and you need to find out what happened and report it back. And again, so David Farrell, the postdoc who worked on the project, he came with an idea called microvision. And if you're a detective and you come to a beautiful bathroom like this, you want to know if there are any bugs on the surface or on the toilet. So you can turn on your microvision, which gives you, obviously it's a hypothetical concept. And in the microvision, you see where the bacteria are, if they are in high concentration on any surface. So for example, in this bathroom, you would expect bacteria to be around the toilet, maybe also on the taps in the sink, but not on the door. It's like someone hasn't washed their hands after using a toilet and they were touching their hands, touching the door before they left the toilet. And actually in this particular scenario, this is how the infection got spread into a party barbecue, and an actor was very ill, and it was a major PR fiasco. So this is how the microvision was helping the kids to understand that even if you can't see it in a day life, it is still there. You can investigate people, so you can investigate your cook and ask if this kitchen hygiene is appropriate, if he was using the right temperature on his dishwasher or soap, if he was having 2 different chopping boards, one for meat, one for vegetables, and so all the evidence could be collected, just like in CSI, and it goes into your phone, and in your phone you can have all the evidence, either using the microvision or using the normal evidence. And you can send it to a lab where you can test it for presence of bacteria, and then you can get the results back, and you should puzzle a story together and then report it back to your manager. And again, we saw, okay, how are we going to evaluate it? Kids did enjoy playing it in principle, but how do we know if they learned what they were supposed to learn just from understanding the story? So in this case, the seamless evaluation concept is actually even easier because it is a storytelling. We try to build the questions into the story. So we look at the initial storyline and we have inserted a sort of pre-test, which was a question, a number of options, and a feedback, giving direct feedback to the user as a reinforced learning. Then the story just went on, and at the end there was a post-test when they were reporting back to the manager what actually happened. They would again ask the same questions, given the same answers, and we collected the pre and the post questions inside the game. So for example here, the question is, do you know where E. coli is usually found? And it's a part of the discussion, so you're clicking through anyway. So here you are given an options. E. coli is usually found in the saliva, E. coli is usually found in the bowel intestines. And then you give an answer, yes or no, and then you just carry on. So because of the nature of this mechanics, it was actually much easier to insert the evaluation into it. It's in a way a bit simplistic because it's simply given only 2 of the options. So you will not be testing the knowledge in other way than multiple choice questions, but for the reason of the evaluation, this was sufficient. And at the end is a debriefing phase when the manager asks you, and she asks you the same questions and gives you an option, and you choose yes or no. And the same question was asked at the beginning, so we can collect the data from the pre and from the post without the kids even knowing. So it is a STAR evaluation framework where we actually try to break down all the puzzles, have some red herrings, have some kind of clues, and they have to be proved and disapproved, and we have to build the questions into it from the beginning and at the end of the briefing, collect the pre and post results in the story. So the evaluation of the seamless evaluation, so how well this worked, we have 145 participants, and they were asked a bunch of questions, whether they felt it was obstructive, and whether they felt it affected their use, etc. What was their perception? And in this case, it was 94%. They played both options. They actually preferred the evaluation to be integrated in the game flow. So again, the kids just didn't think this was something which was decreasing their emergence and their game experience. And the fun small study we did was the issue with this game was it really heavily relies on learning skills. Some of the kids have got fantastic learning skills and they can read very well. Some kids, even though it's age 14, they're not fast readers. So at the beginning, they just clicked through the introduction and they got lost and didn't know what to do. Unless they knew CSI game from before, right? So it really heavily relies on good skills. So what we actually figured out from one of the big studies was we have to do a training mission before the kids who don't know how to play it and who are not good readers before they can start playing it. Otherwise, they just don't enjoy it. So the kind of split between those who didn't like it because of the reading and those who did was quite significant. So we developed a training mission, which was kind of trying to show how the game works. If you collecting smelly socks in a locker's room for a football team, and then you are taking from the locations, you show how to collect the evidence, how to turn the microvision. So in a very short kind of summary, the game shows you the various principles before you go on and play it for real. So we evaluated this in a school in London, thinking how it actually improved the training mission. We again had 2 groups of kids, one playing the training, one without the training. And we want to know what was the usability of the game, if it decreased the usability or if they actually didn't mind. So we looked at the usability evaluation questionnaire using called SUS, I'm sure you know it, and we adapted the SUS to become game specific. So as opposed to asking about the generic program, you actually ask about the game, and we have also changed using for playing to make the language specific for the SUS. And we evaluated usability of the training mission and the non-training mission using the SUS. And again, so we only found statistical significance for one of the questions, which I found the game awkward to use. The rest of it wasn't statistically significant. However, in terms of the results that the kids gave us, it was seen as the usability of the game was okay and didn't decrease the immersion. So using the training is a good way of getting sort of around the problem of the kids who are with strong peers. Okay, just to summarize, the international audience for the kids was actually interesting. The slide is here for one reason. Both of the games were initially launched in English when we did them, and then they were translated. And it took like several months to have all the translations and they all launched in all the languages. So initially, and these are the initial results, we actually got the country data, and surprisingly enough, Portugal and France were the second and third country playing the English version before the translations were launched. Obviously, UK was the highest because we were developing it, and we had a lot of school engagement. The same was for the Sofia game. So somehow kids in Portugal were, I don't know why not in Spain, but kids in Portugal seemed really keen to play the games initially, even though it was in English. So we kind of thought it would not be the case because it's not the biggest country, and it's obviously the English level. It depends on what school they go to. Why out of the
English level in Portugal is much better than in Spain because usually TV is not translated into Portuguese.
So they used to it. Yeah. Because we thought that maybe Germany or maybe France has got better education, but it was Portugal. So they were very happy about seeing this result. They came second after the UK kids. And just to show how kind of these projects can actually have a meaningful impact on public health, this is kind of the site usage since one of the project. And there was a massive increase during the swine flu in 2009 because the HPA needed to have some educational resource to recommend to schools. And this was just launched, so they actually linked to the EBAC project from the HPA, Health Agency website, during the time of the pandemic as a recommended schools project about hygiene and infection. And our site has quadrupled in the traffic. So even something which is a games project actually can have a meaningful real-life application. You got a lot of media coverage from BBC and from TV covered our conference in Morocco. A lot of work around Twitter was covered by media. And I'd like to thank you to all the staff members who worked with me in CERC and my new colleagues from UCL who contributed to this body of work in various phases. I specifically want to thank you to David Farrell, who was instrumental in the games project, and my new researcher, Andrea Molnar, who did a lot of these interventions and the studies I have been describing here. So thank you very much for listening to me, and I take questions.
Question?
Yeah. I have a few actually. I would like to start with a question about the last part about serious games. There's something I feel also in our own work when we conduct evaluation of serious games. That is that you spend a lot of effort and time to developing a game, and then when it comes to evaluate if it's really successful, then you realize that you are not covering such a big amount of topics or knowledge as to really be able to measure differences, right? So I think that's one of the. I also have the feeling that I saw part of that in your presentation. I think it's good to see that we made